Good day, everyone. Today, I'm going to present a case study involving an animal-transmitted viral disease, Hantavirus. For this report, I'm going to discuss the background of the virus as well as its management and prevention. Also, a clinical case study will be tackled involving the virus. For the background information about the case, a previously well 36-year-old Sri Lankan Sinhalese man from Kandy, Sri Lanka, was admitted to a tertiary care hospital. Before the admission, the patient was in good health and works as a farmer involved in paddy cultivation with possible rodent exposure. There was no significant medical illness in his family as reported in his medical history. He was an occasional drinker and did not smoke. He suffered a 3-day history of an acute febrile illness associated with high spiking fever with chills and rigors. Myalgia, or muscle aches and pain, was also observed. Shortness of breath with a non-productive cough was observed 1 day prior to admission. He also suffered arthralgia, which is pain in the joints, and was anuric, which is the non-passage of urine often caused by failure in the function of kidneys, for 12 hours prior to admission. Furthermore, he was unable to move due to severe muscle cramps in his lower limbs. Before we proceed with the case, let us first discuss about hantavirus. Hantavirus infection is a severe emerging zoonotic disease from the virus family Bunyavirinae caused by the virus hantavirus, which is a ribonucleic acid virus. It causes 2 life-threatening human diseases. First, hemorrhagic fever with renal syndrome or HFRS and hantavirus pulmonary syndrome or HPS. As you can see from the image right below, the virus genome consists of a spherical lipid envelope, 4 viral proteins, and the 3 segments of negative-stranded RNA, which makes up of the large segment that encodes RNA polymerase, the medium segment that encodes glycoprotein precursor G1 and G2, and the small segment that encodes the nucleic capsid protein. Hantavirus disease is categorized as New World or Old World depending on the place it is observed. New World hantaviruses are observed in Americas, which cause HPS, while those hantaviruses that are found in Europe and Asia are known as Old World hantaviruses, which cause HFRS. The discovery of hantaviruses in the Old and New Worlds was due to the 2 major outbreaks that happened in the past century. The first one was in Korea, and the second outbreak was in the Four Corners region of the United States. The emergence of hantaviruses for the past decades is caused by the intrusion of humans in the environment of the animal carrier of the virus that are heightened by anthropogenic factors. Hantavirus maintains its cyclical transmission between infected rodents with incidental infection of humans. The main reservoir of hantaviruses are associated with rodent species or the Rodentia, family Muridae, subfamilies Murinae, Arvicolinae, and Sigmodontinae. The causative agents differ between the new and old world hantaviruses. HFRS in humans is caused by old world hantaviruses with its etiological agent known as Hantaan virus and its reservoir, the stripe-field mouse. On the other hand, the etiological agent of New World HPS cases is the Cinnabar virus and its reservoir, the deer mice. Today, many additional pathogenic new and old world hantaviruses are already identified and characterized. The virus enters the body of humans through respiratory route by inhalation of aerosols from the contaminated feces, urine, or saliva of the infected rodents. Once it enters the body, it spreads from the lung parenchyma and the virus is taken up by phagocytes and migrates to regional lymph nodes, and later disseminated to distant organs including the heart, liver, and kidney. People who are in close contact with infected rodents have increased infection risk. The spread of virus from infected person to an infected person does not normally occur, although one exception was observed with the Andes hantavirus strain in South Argentina in 1996, of which sporadic person-to-person transmissions were reported. The immune response of the host to the infection is the activation of innate immune responses such as the type 1 interferons and pro-inflammatory cytokines. This is possible since the host cells have the ability to recognize pathogen-associated molecular patterns. The innate immune responses are responsible for restriction of viral replication and spread. However, hantaviruses have developed multiple mechanisms to elude the IFN response of the host, thus allowing viral replication and spread. One example is the virus RNA transcripts having a 5' monophosphate at their terminal instead of 5' triphosphate. However, the ability of the innate immune response to induce adaptive immune response counters the hantavirus infection through the humoral and the cellular response. The production of virus-specific IgM as well as cytotoxic CD8 T cells play important roles in virus elimination. HPS have some overlapping syndrome to HFRS except that the lungs are targeted for capillary leakage instead of the kidneys. However, for the past years, the number of reports of both diseases have increased, with HFRS cases observed with lung involvement and HPS cases with renal involvement. It is then probable that in the near future, syndromes of both diseases will further converge along their clinical course. HPS with HFRS has an incubation period ranging from 7 to 36 days, with HPS having a more severe mortality rate of 50%. HPS is a severe acute disease associated with a rapid onset of respiratory failure and cardiogenic shock. HFRS, on the other hand, involves the system of capillaries and venules, inducing various hemorrhagic manifestations and circulation disorders. There are 5 clinical stages of the hantavirus infection causing HPS or HFRS: the febrile phase, hypotensive phase, oliguric phase, polyuric phase, and convalescent phase. The febrile phase of HPS resemble of that flu-like symptoms, while of that of HFRS are thirst, restlessness, and vomiting. Hypotensive stage in HFRS shows symptoms of vascular leakage, abdominal pain, and tachycardia. During the oliguria stage, the urine output is less than 400 ml per day. This stage accounts for approximately half of all hantavirus-related deaths, and patients are at risk of hypertension, pulmonary edema, and complications of renal insufficiency. Death from HFRS is usually from complications of renal insufficiency, shock, or hemorrhage. Also in HPS, most deaths occur during cardiopulmonary phase, with progressively worsening thrombocytopenia accompanied with headache, back pain, abdominal pain, and diarrhea. There is also hypertension, respiratory failure, and oliguria during this phase. If patients survive the first 3 phases, polyuric phase sets in. Polyuric phase is the increase in production and passage of urine. Convalescent or recovering phase then sets in and may take 3 to 6 months. Diagnosis of hantaviruses is usually made on the information given by the clinical and the serologic findings. Serological tests that detect IgM or IgG antibodies, which are present after the onset of symptoms of both HFRS and HPS to hantaviral antigens in serum, are the most common approach. These include indirect immunofluorescence assay, immunoenzymatic assay, and enzyme-linked immunosorbent assay. Another test for serological diagnosis and typing of suspected hantaviral infections are immunoblot and neutralization tests. A molecular diagnosis using reverse transcription polymerase chain reaction can also be used to detect the viral RNA. Differential diagnosis of hantavirus can present as certain types of disease, especially when the prodromal phase of the infection is indistinguishable from numerous other viral infections. Leptospirosis, Legionnaire's disease, mycoplasma, Q fever, chlamydia, and septicemic plague are some infections which might present as hantavirus. Currently, there are no antivirals, vaccines, or immunotherapeutics licensed by the US FDA for the treatment and prevention of the hemorrhagic fever viruses, including HFRS and HPS. Although the use of ribavirin as an antiviral drug against hantavirus disease was observed in some studies, the results were inconclusive. The treatment of patients suffering from HFRS or HPS is primarily supportive. This includes the moving of patients into a unit with intensive cardiopulmonary care, treatment of symptoms, and focusing on the blood pressure as well as oxygenation is given when the onset of pulmonary edema is observed. Intubation and mechanical ventilation are provided as required. The absence of effective antiviral drugs and vaccines against hantaviruses gives rise to the importance of trying to prevent an infection. Prevention is based on rodent control, such as reducing rodent shelter, and preventive measures for persons who have occupational exposure to wild rodents. For this part, I will discuss a case study report, specifically an atypical case wherein hantavirus infection is seen mimicking leptospirosis, written by the Logama and his colleagues. As we discussed in the first part, this case revolves around a previously well 36-year-old Sri Lankan Sinhalese man with rodent exposure presenting clinically similar symptoms to leptospirosis with an acute febrile illness with myalgia, with liver involvement in the form of transaminitis, cardiac involvement in the form of myocarditis, acute kidney injury, and pulmonary involvement. On admission, the patient had clinical features suggestive of cardiac, liver, and renal involvement with low blood pressure. Tests confirmed the liver dysfunction with renal involvement. Electrocardiogram, as well as elevated troponin, suggested possible myocardial involvement, along with X-ray findings of bilateral pulmonary infiltrates, which could be due to pneumonitis or pulmonary hemorrhages. A working diagnosis of severe leptospirosis with multi-organ dysfunction was made based on the findings of the patient's background of significant mud exposure and epidemiology of the locality. Differential diagnoses such as dengue, rickettsial infections, atypical pneumonia, severe influenza, and hantavirus were considered. Dengue was a possibility as it was epidemiologically common and presents a similar pattern. Rickettsial infection was considered since they have a similar presentation with multi-organ involvement. Atypical pneumonia was also considered since the patient had cough with shortness of breath on admission as well as the other symptoms observed. Severe influenza was also possible since a similar presentation of fever, myalgia, and type 1 respiratory failure with multi-organ dysfunction is seen. Lastly, a diagnosis of hantavirus was considered due to close resemblance of symptomatology with leptospirosis. The patient was treated with third-generation cephalosporin and doxycycline on admission to cover the possibilities of leptospirosis, rickettsial infection, and atypical pneumonia. He was intravenously administered with fluid for hydration, considering the possibility of myocarditis, and was started on inotropes. After weighing the risk and benefits and after covering with broad-spectrum antibiotics, methylprednisolone was considered for the patient. Elevated transaminases on admission, which was initially believed to be due to liver involvement in leptospirosis, was entertained again by the differential diagnosis of hantavirus. N-acetylcysteine was administered to the patient until transaminases were less than 300. The patient had a successful treatment outcome. Treatment was observed for succeeding days after admission. On admission, he was started on intravenously administered noradrenaline as his blood pressure remained low. He was given cefotaxime and doxycycline after taking blood cultures. N-acetylcysteine infusion was started for his elevated transaminases. On day 2 of illness, the patient has clinically improved with less myalgia. Inotrope requirement was reduced from 0.8 to 0.2 microgram per kilogram per minute, and his oxygen requirement improved from 10 to 2 liters per minute via nasal prongs. His urine output was 525 ml in the last 24 hours. On day 3 of illness, his blood pressure was normalized without inotropes. The patient was tested against the diagnosis of dengue on day 3, fever, and the resulting NSI antigen test was negative. Throat and nasal swabs were also negative for influenza A viral RNA. On day 4, his saturation on air was 99%. Over his subsequent 5 days, his clinical condition gradually improved. With prescription of 1 gram of methylprednisolone which continued for 3 days, and intravenously administered cefotaxime as well as orally administered doxycycline for a total of 7 days. On day 7, he was discharged of hospital admission after an eventful recovery. The patient underwent a microscopic agglutination test for IgM and IgG against leptospira that turned out to be negative. However, the blood that was taken from the patient on day 7 tested positive for IgM against hantavirus. In this case, the diagnosis of hantavirus was done on day 7 and was initially diagnosed as leptospirosis due to both illnesses causing similar symptoms. The diagnosis of hantavirus was done using the immunofluorescence assay, which is used to detect IgM against hantavirus on 1:100 dilutions, which tested positive and confirmed the diagnosis. Ribavirin, a nucleoside analog, was not administered since the diagnosis was made retrospectively after apparent recovery. If we look at the patient's symptoms again, we can see that the patient had a neutrophils leukocytosis with thrombocytopenia, which was similar to hantavirus infections that include leukocytosis with increased myeloid elements and atypical lymphocytes and thrombocytopenia. The symptoms of the patient, as shown, were overlapping with both renal or HFRS and cardiopulmonary HPS involvement. The medications that were administered to the patient, especially the steroids, did not have any side effects to the patient but was observed to show a clear clinical and biochemical improvement following administration to the patient. Immunofluorescence assay sensitivity for combined IgG and IgM analysis followed by repeat testing should be done again after 4 weeks for observance of rising titer in the convalescence, which would be ideal in order to verify the diagnosis. However, the patient did not turn up in 4 weeks for another serological testing. For the conclusion of the paper, they believe that hantavirus should be considered in the differential diagnosis of a patient presenting with leptospirosis-like illness with multi-organ involvement. That is all, and I hope you have learned something about my presentation. Thank you.